So chapter 34 is talking about understanding the gastrointestinal, hepatic, and pancreatic systems. Chapter 34 is talking about Crohn disease. Crohn disease is common in teens as well as young adults. Crohn disease is a disease that can occur anywhere in the GI tract as well as outside of the GI tract. The disease progresses and obstruction occurs because the intestinal lumen narrows with inflamed mucosa and scar tissue. And just to point out something on this picture, it show you a fistula. And do you all know what a fistula is? So a fistula is an abnormal connection between structures. And typically, due to the fact it's being abnormal, this connection should not be occurring. Some patients have a fistula, just to say, between their vagina and buttocks, in which, that can possibly contribute to infection because it should not be a connection where stool can travel in an individual's vagina. Fistulas do occur in that area. So a fistula is definitely an abnormal connection. And let's talk about the signs and symptoms of Crohn disease. And with Crohn disease, the patient can present with diarrhea, which can be bloody due to the fact that you're dealing with an individual who has an inflamed mucosa. Patients can present with fever, fatigue, weight loss, that type of thing. And those are some of the most common signs. And in order to diagnose Crohn disease, the patient will require an endoscopy. Biopsies can occur to actually diagnose the disease. What's a paragraph I'm looking for that I don't see on here? So the paragraph I'm looking for, it tell you chronic diarrhea contributes to fluid deficit and electrolyte imbalance. There can also be inflammatory systems outside the GI tract of the eye, liver, bile ducts, skin, and joints. Periods of remission and exacerbations occur. Physical or psychological stress may trigger exacerbations. So going through some stress can cause the disease to flare up. It can be a trigger for the disease. And it just gives you a list of medications that's used to treat Crohn disease as well as ulcerative colitis. And we're thinking that this patient is experiencing inflammation. What are some medications that help lower inflammation, or that helps to prevent inflammation?
Ibuprofen.
Motrin can contribute to a decrease or prevention of inflammation.
Steroids.
Steroids, definitely, yes. NSAIDs as well. But the only thing with NSAIDs, we know NSAIDs, non-steroidal anti-inflammatory drugs, they do cause some GI upset. So if an individual already got something going on with their GI system and you're giving them non-steroidal anti-inflammatory drugs, it could potentially worsen it, to say, if the medication is not being taken properly. Right here where it say Cortico Steroids, typically medications where you just even hear the word cort, you want to know it's a steroid. And of course, if you hear steroid in it, it's definitely a steroid. And steroids do work to decrease inflammation. It works to decrease inflammation. It works to prevent inflammation. And these are some of the common steroids: Medrol, Ciamedrol, prednisone. And even with those medications, a patient has to be weaned off those medications, and steroids have multiple side effects. So as you progress in the program, you will learn more about the multiple side effects that steroids have, from weakening an individual immune system. Patients can experience weight gain from steroids because it increases the metabolism, the patient appetite. What else? Steroids have multiple side effects that as nurses, we have to be aware of. So it's multiple medications patients can be placed on for Crohn disease as well as ulcerative colitis. You want to review the medication list. And it talks about the therapeutic measures for Crohn's disease, and it informs your treatment is individualized based on the individual symptoms. Some patients need anti-diarrhea medication. Depending on the damage that has occurred through the GI tract, more so the intestines, some patients need a colectomy, where they will have to get a portion of the intestines removed. And even in that event, if the patient did get a portion of the intestines removed, the surgeons can connect the remaining intestines together, or they may even have to give you a colostomy bag, a colostomy bag. And sometimes when patients get colostomy bags, the colostomy bags can be temporary. And for some patients, a colostomy bag will be permanent. So colostomy bags, individuals who get colostomy bags, they may tell you, a doctor then said, they're gonna do my surgery and I won't have this forever, that type of thing. And that may actually be true. So a colostomy bag can be reversed. It just depends on the reason an individual has it. And it talks about ulcerative colitis. And we discussed ulcers, where, to me, when I hear the word ulcer, I'm automatically thinking of a sore. I'm thinking of an open sore. Colitis, what is this referring to?
Is it inflammation?
Inflammation of what?
The colon?
Correct. So ulcerative colitis, inflamed colon, that's what I received from colitis, and ulcerative make me think of a sore. It makes me think of sores. And ulcerative colitis occurs in the large intestines and the rectum. And it talks about the signs and symptoms of ulcerative colitis. What do you expect to see with a patient who has ulcerative colitis? What are some signs and symptoms?
Diarrhea.
Yep, maybe some diarrhea.
Abdominal pain.
Yep, some pain, patient going through pain. They got ulcers in their intestines. The inflammation. What about the appetite? Because if you have too much pain, you may not even be able to eat comfortable. You may have difficulty with sleeping. And it talks about diet or psychological stress may trigger or worsen an attack of the symptoms. And some of the complications that can occur range from hemorrhage. Patient may develop cancer, and it may even affect the bones, where it contribute to osteoporosis, that type of thing. And it talks about therapeutic measures. Will somebody read that first paragraph of therapeutic measures?
Therapeutic measures. Diet, lifestyle changes, medications, and surgery are used for treatment. Many of the medication classes used with Crohn disease are used for ulcerative colitis. Foods that cause gas or diarrhea should be avoided. Because the offending foods may be different for each patient, foods are tried in small amounts and eliminated if they are thought to cause symptoms. In general, high fiber foods, caffeine, spicy foods, and milk products are avoided. Diarrhea may increase the need for fluids to prevent dehydration. Surgery is considered for excessive bleeding, severe symptoms, perforation, or toxic megacolon. Because ulcerative colitis usually involves the entire large intestine, the entire colon and rectum are removed for a protocolectomy with ileostomy. This procedure is curative. The anal sphincter of the rectum can be preserved for an ileoanal pouch procedure. This is not curative, as the disease can return in the preserved rectum. An ileoanal
You have
pouch.
to read that paragraph. Sorry.
Okay.
Thank you. Will you also
Nope.
read right here where it say identification of emotional status?
Yes, I'm just changing my view real fast. That's why I'm having an issue reading it real quick. 1 second.
Okay.
Because I got the pictures on the side up here. Okay, sorry about that. Now I can see it. And you said which one again?
Identification of emotional status right here.
Okay. Identification of emotional status, coping skills, and verbal and nonverbal behaviors is essential. The patient may withdraw from family and friends because of frequent bowel movements. Anxiety, sleep disturbances, depression, and denial can be problems. If surgery involving an ileostomy is planned, the patient is at risk for altered body image.
So when you think of Crohn disease as well as ulcerative colitis, what are some nursing diagnoses? What are some nursing diagnoses for Crohn disease and ulcerative colitis?
At risk for pain, at risk for depression,
Diarrhea. Yeah.
at risk for skin integrity.
Mm-hmm. At
At
risk
risk
for
for infection.
electrolyte imbalance, that type of things. So it also talks about irritable bowel syndrome. And with irritable bowel syndrome, when I think about that, I'm thinking about something that's irritating the bowels, something that's irritating the bowels. And with irritable bowel syndrome, the individual can present with either diarrhea, or the individual can present with constipation. So it either causes the colon to contract too slow, or it causes the colon to contract too fast. And if the colon is contracting too slow, what is that going to contribute to?
Constipation.
It's going to contribute to constipation. And if the colon is contracting too fast, what would that contribute to?
Diarrhea.
Diarrhea.
Diarrhea, and the etiological factor is not known. There's no known cause for irritable bowel syndrome. And diagnostic test, physician may do a physical examination, endoscopy, CT scan to actually rule out the disorder. Therapeutic measures. Will somebody read therapeutic measures?
IBS is a chronic condition, but symptoms can generally be controlled with diet, lifestyle, and stress management and medication. Treatment varies based on the bowel pattern. In general, adequate hydration, exercise, rest, and avoiding food triggers, especially those that cause gas and contain gluten or FODMAPs, are important. A high fiber and high bran diet and fiber supplements may help to form a softer, larger stools to relieve constipation. Eating smaller, frequent meals can be helpful in reducing bowel contractions. Patients can keep a diary of foods eaten, stressors, and symptoms. This can help the HCP identify flare-up triggers. Stress management and behavioral therapy are helpful in relaxing the bowel as well as contributing to overall health.
Okay. And typically, treatment also revolves around a type of IBS. And with irritable bowel syndrome, again, patient can present with constipation, patient can present with diarrhea. So depending on how the patient present dictates the treatment that the patient will actually receive. And it's talking about abdominal hernias. And with abdominal hernia, a hernia is an abnormal protrusion of an organ or structure through a weakness or a tear in the wall of the cavity that normally contains it. Hernias occur from increased intra-abdominal pressure, such as coughing, straining, heavy lifting. Those are things that contribute to a hernia. And it talks about prevention. With abdominal hernias, if a patient lay flat, you wouldn't, the hernia would disappear, is likely to disappear. So with an abdominal hernia, patient lie flat in supine position, the hernia would disappear. Will somebody read prevention?
Congenital defects cannot be prevented. However, reducing strain on abdominal muscles is helpful. Those who do heavy lifting, tugging, or pushing should wear a support binder or avoid the lifting. A healthy lifestyle of maintaining normal weight, not smoking, and eating high fiber foods is recommended.
Okay. And let's show you some of the locations that hernia can actually form in the abdominal area. And typically the hernias, as far as where they form, is how they actually get their name. It's an umbilical hernia because it's around the umbilical area, an inguinal hernia because it's near the groin. This is a femoral hernia because it's near the femoral bone. It's near the femur. So they get their names from the location that they're located at. And it talks about complications. Will somebody read complications?
As an incarcerated hernia may become strangulated in the blood and intestinal flow, are commonly cut off in the trapped loop of bowel. Strangulated hernias do not develop in adults very often. Incarcerated Incarceration leads to an intestinal obstruction and possibly gangrene and bowel perforation. Symptoms are pain at the site and of the strangulation, nausea and vomiting, and colically abdominal pain.
Mhm. And with therapeutic measures for hernia, hernia are diagnosed by physical examination because we know the hernia can be seen, it can be felt, it can be palpated. So for some hernias, no treatment is required. For other hernias, patient may have to go into surgery, especially if it's affecting another organ, or if this organ is being deprived of oxygen or at risk of being deprived of oxygenation or tissue perfusion, patient will require surgery. Talking about absorption disorders, what comes to mind when you think of absorption disorders? What comes to mind when you think of absorption disorders?
Some type of liquid or nutrition
Have a
being
problem with digesting
absorbed.
stuff.
Yeah.
Yeah, I'm thinking more so it's some type of difficulty with digestion, with the body receiving whatever nutrients, vitamins, etc. So it's some type of issue there. It also makes me think if a patient having absorption disorders, I think about some of the things that it's going to affect. What would having an absorption disorder affect if I'm experiencing it? Maybe it's going to experience my weight. Maybe it's going to affect my weight, affect my appetite. Those are the things I'm thinking. Maybe it contribute to malnourishment. The pathophysiology and etiology, will somebody read the first two paragraphs?
Malabsorption occurs when the GI system is unable to absorb one or more of the major nutrients. Some causes of malabsorption are ileal dysfunction, jejunal diverticular, parasitis disease, celiac disease, enzyme deficiency, and IBD such as Crohn disease and ulcerative colitis. The primary malabsorption disorders are celiac disease and lactose intolerance.
Would you read the next paragraph?
In celiac disease, a sensitivity to gluten is thought to cause malabsorption of protein. Gluten is a protein found in wheat, barley, and rye. Oats may become contaminated with gluten in the milling process of these other grains. You want me to read the other one too?
No, that's it. Thank you.
Okay.
And it talks about complications. Will somebody read complications?
Vitamin K. Oh, go ahead.
Go ahead, Kawana.
Vitamin K deficiency and resulting hyperthrombinemia can increase the risk of bleeding. Calcium deficiency can be severe enough to cause bone pain and neuromuscular hyperirritability, including tetany. Folic acid, vitamin B12, and iron deficiencies can result in I cannot see this. Is it glossitis, stomatitis,
Glossitis, yeah.
anemia, and dry, rough skin, and celiac disease, dermatitis, herpa. I cannot, hold on one second.
Herpetiformis.
Occurs, which is a skin rash with severe prudeness and blistering. It's really blurry for me, I'm sorry.
No problem. It talks about therapeutic measures. It talks about celiac disease. Celiac disease is a disease that will result in a gluten-free diet. And typically, an individual who consumes gluten, their immune system reacts. And gluten is a protein found in wheat, barley, and rye. So those are some foods that a patient needs to avoid. You do want to know foods that have gluten in it. So if you all do have a patient who's on a celiac diet, you know what's appropriate for them and what isn't. Talks about lactose intolerance. Lactose, anytime you hear an os at the end of a word, you always want to think of sugar. Lactose is the sugar that's in milk. So typically, one of the side effects of calcium is calcium should be causing constipation. That's what calcium should contribute to. It should contribute to constipation, but for an individual who consumes calcium and they like, you know that cheese gonna make me go, or that milk gonna make me go, they are intolerant of lactose. If you are consuming calcium and it's causing diarrhea, you are intolerant of lactose, but calcium should actually cause constipation. And your patient who has absorption issues, what should you be monitoring as a nurse? What should you monitor as a nurse when your patient has absorption issues?
Weight loss.
Yeah, I want to monitor your weight. What else? I want to monitor your intake, your output. I want to monitor you for electrolyte imbalance, for signs and symptoms of an electrolyte imbalance. You know, we need to look at your labs. Talks about intestinal obstruction. What do this mean? What do intestinal obstruction mean?
Some type of blockage, maybe.
Yeah, some type of blockage, yeah, in the intestines. Okay. The severity of the obstruction depends on the area of the bowel affected. The amount of occlusion within the lumen and the amount of disturbance in the blood flow to the bowel. So if a patient has an obstruction in the right, the left upper quadrant and the right upper quadrant, and you are listening over that obstruction, do you expect to hear absent bowel sounds at that area, hyperactive or hypoactive?
Would they be absent?
Yep, it's a possibility of hearing, well, not hearing, but it's a possibility the patient will have absent bowel sounds or hypoactive bowel sounds. Proximal to that area, so just to say you got a straw, we're looking at the straw as the intestines, and the middle of that straw, we have some type of blockage. So you're not able to suck no Kool-Aid out that straw because of this blockage. Proximal to the blockage, will you hear hyperactive bowel sounds, hypoactive bowel sounds, or absent?
Hyper. It'd be hyperactive before
It'll be
the
hyperactive. And the reason, why do you feel like it'll be hyperactive? Or no?
I feel like because it's not able to push through because of that obstruction. It's like building up.
Yeah, and it's trying to fight to push that obstruction through. And with an obstruction, what might be a treatment option?
Enema.
Yeah, if it's stool, we know that
Laxative.
the obstruction is stool, depending on the location, may be an enema, some form of an enema, or a patient may have to be decompressed. But we may have to put you on a suction tubing. And it talks about a small bowel obstruction. And we know in the small bowels is where most absorption occur. Most of the absorption occurs in the small bowels, where in the small bowels, we know the gallbladder secreting bile, the liver is absorbing those different nutrients, poisons, etc. Most of that is occurring in the small bowels. When obstruction occurs in the small bowels, a collection of intestinal contents, gas, and fluid occurs proximal to the obstruction. And it just talks about with a small bowel obstruction, some of the signs and symptoms that you may expect to see. So if I have a small bowel obstruction, what are some of the things that may occur? Or do you expect this patient to report subjectively, or you expect to observe objectively?
Pain and constipation.
Pain.
Yep, they may complain of constipation, they may complain of pain. How about vomiting or some nausea? Talks about therapeutic measures. Once it's clear a patient do have a bowel obstruction, patient will be made NPO due to the possibility of having to go into surgery to be decompressed. Mechanical obstruction requires surgical intervention, such as a removal of tumors, release of adhesions, or a bowel resection. Talks about a large bowel obstruction. And with a large bowel obstruction, the large bowel is less common and not usually as dramatic as the small bowel obstruction. Will somebody read therapeutic measures for a large bowel obstruction?
If impaction is present, enemas and manual disimpaction may be effective. Other mechanical blockages may require surgical resection of the obstructed colon. A temporary colostomy may be indicated to allow the bowel to rest and heal. Sometimes an oh my God, what did I say? Ileoanal, ileoanal anastomosis is done. A stent may be placed to expand the colon to facilitate fecal movement if surgery cannot be done immediately. A patient who is a poor surgical risk may have a sectomostomy and opening from the celium to the abdominal wall to allow diversion of stool. A consult with a nutrition support team to evaluate for PN should be made.
Let's talking about Anorectal problems. So with anorectal problems, it's talking about hemorrhoids. Hemorrhoids are enlarged veins within the anal tissue. Most hemorrhoids are caused by straining during bowel movements. Hemorrhoids can present internal or they can protrude where you can see them externally. It talks about treatment is aimed at preventing constipation, avoiding straining during defecation, maintaining good personal hygiene, making lifestyle changes to relieve hemorrhoid symptoms and discomfort, prolonged standing and sitting is to be avoided, increased fluid intake and stool softeners can be used to reduce the need for straining. Daily SIDS baths increase circulation to the area and aid in comfort and healing. Astringents such as witch hazel can be used for symptoms relief. Anti-inflammatory medications may be tried, such as steroid creams or suppositories. Alternating ice and heat helps relieve edema and pain for thrombosed hemorrhoids. The blood clot is removed by a healthcare provider. Surgery may be necessary for internal hemorrhoids. If the patient has surgery, analgesics are given as needed because the many nerve endings in the anal canal can cause severe pain. Okay, and it talks about anal fistures. And anal fistures are cracks or ulcers in the lining of the anal canal associated with constipation and stretching of the anus with passage of hard stool. So where hard stools are causing cracks or ulcers in the anal canal. And we know an abscess, let's talk about anorectal abscess. Abscess are typically filled with pus. It's a collection of pus. And typically pus is a sign of infection. So an anorectal abscess, we know part of the treatment would be what? What would part of the treatment be?
Antibiotic.
An antibiotic. We want to put you on an antibiotic. You have an abscess. We know that abscess presents pus, and pus is a sign of infection. It's talking about lower gastrointestinal bleeding. If you suspect your patient is bleeding, what might be the appropriate lab test for them? If your patient, you suspect internal bleeding. What is the appropriate lab test if we suspect internal bleeding?
Hemoglobin?
Yes, let's get a hemoglobin and a hematocrit. Let's do a CBC, a complete blood count. We know the complete blood count can give us the RBCs, white blood cells, that type of thing. We want to get a CBC. We want to get the hematocrit, that hemoglobin. It talks about lower gastrointestinal bleeding. Would somebody read etiology as well as signs and symptoms? Etiology and signs and symptoms.
Bleeding from the GI tract is seen in the stool. When blood has been in the GI tract for more than 8 hours and has come in contact with hydrochloric acid, it causes melena or black and tarry stools. The presence of melena indicates bleeding above or in the small bowel. Bleeding from the colon or the rectum is usually bright red. Significant blood loss causes hypertension, lightheadedness, nausea, and diaphoresis. The patient may be pale and have cool skin. The onset of tachycardia and worsening hypotension indicates hypovolemia shock and should report it to the healthcare provider immediately.
And it talks about therapeutic measures for lower gastrointestinal bleeding. Treatment involves correction of the cause of the bleeding. Surgery to correct diverticulosis, correct IBD, or resect cancer may be considered. It's talking about colorectal cancer. This is one of the cancers where low fiber diets is a contributing factor. The thing that we have to accept is the foods that we eat have germs all over it. What foods would you all say is the most germy?
Like meat,
I would say fruit from the
or
from the
fruits and
market.
vegetables.
Fruits
Yeah.
and fresh fruits and
Fresh fruits and
vegetables.
vegetables, yeah.
Fresh fruits and vegetables will be the most germy. Everybody coming to rub their hands through it. Let me see if I want this bulk of broccoli. Let me see if I want these greens. Let me see if I want them apples. Well, germs are all over it. So it's just something to consider when you are dealing with patients who has a weakened immune system. We probably want to tell them you're not getting no fresh fruits or vegetables. You will not be getting no fresh fruits or vegetables, because them fresh fruits and vegetables can have germs all over it. And one of the things about when we do cook foods, when we put germs under 120 degrees or higher, that works to kill those germs. Certain germs will not die under 120 degrees, but the mass majority of all germs will die once you put some heat to them. But part of the reason I'm saying that is if we know that most of the foods that we eat have all these germs and stuff like that on it, that type of thing, it's important for us to have bowel movement regularly. You know, for some people, when I think about from the mouth to the anus, I always picture that straw. Some people's straw is completely clogged up. So if your straw completely clogged up, that be that individual, as soon as they eat, it's, oh, girl, I got to go run and do the number 2 real quick. You know, every time you eat, you got to run and do the number 2. You probably need to go and take a little laxative to flush yourself out. Because if your straw is completely clogged up, you know, you have them germs that's just sitting there. Them germs that's sitting there growing, cancer sitting there growing, that type of thing. You need that stuff flushed out your system. So sometimes it is beneficial to, well, first we want to think non-pharmacological when we know, hey, my straw is completely filled. Non-pharmacological, okay, let's start increasing fiber in our diet. Let's start eating those high fiber foods to flush our GI tract out. And when that's not effective, that's when we want to go to the pharmacological use. Let me try laxative. So as nurses, anytime that we recognize there's an issue, before we try pharmacological interventions, we want to try non-pharmacological interventions. But with colorectal cancer occurs from a lack of fiber, is a contributing factor. People with a personal or family history of ulcerative colitis, colon cancer, polyps of the rectum or large intestines are at high risk for developing cancer. And we know, chances is if our family have diseases, we are automatically at risk for those diseases as well. You know, if grandma got hypertension, daddy got hypertension, brother got hypertension, you are at high risk for hypertension unless you prevent it. Grandma got breast cancer, auntie got breast cancer, you at high risk for breast cancer, so you want to put those different interventions in a place to prevent it. Let me go get screened for breast cancer early, that type of thing, and as often as possible. So due to the fact that I have a family history of this cancer, if I'm being screened early, hopefully the cancer can be recognized early. And, I don't have to go through such harsh treatment, because cancer treatment, it can be a bit much. And it also points out colorectal cancer has also been linked with previous gallbladder removal and dietary carcinogens. What are carcinogens? It's another word for cancer, blood cancer. A major casualty factor is the lack of fiber in a diet, which prolongs fecal transit on time, and in turn prolongs exposure to possible carcinogens. Signs and symptoms of colorectal cancer. Will somebody read the signs and symptoms?
Manifestations of colorectal cancer vary according to the type of tumor and the location. A change in bowel habits is the most common symptom. Blood or mucus in the stools may occur. All tumors cause varying degrees of obstruction. Tumor in the descending colon and rectum generally do not cause nausea or vomiting, anemia or weight loss.
The treatment options for colorectal cancer will be some of the same treatments for any other cancer: surgery, radiation, chemotherapy, that type of thing. Patient may have to be put on parenteral nutrition, depending on what's actually occurring. And this is showing you some stomas. Some stomas. He's talking about ostomy, incontinent ostomy management. Will somebody read that first paragraph? Will somebody read that first paragraph?
An ostomy is a surgically created opening, traditionally abnormal incision or laparoscopic, that diverts stool or urine to the outside of the body through an opening on the abdomen called a stoma. A stoma is the portion of bowel that is sutured onto the abdomen. A content ostomy uses an internal reservoir to collect stool. The types of abdominal ostomies include ileostomy, colonostomy, and urostomy. The stomas can be end, loop, or double barrel.
And it talks about an ileostomy. The ileostomy get its name because of the location. It's near the ileum. We're at the ileum. An ileostomy is an end stoma formed by bringing a terminal ileum out to the abdominal wall. So that's how I get its name, ileostomy. And with an ileostomy, due to the location, the ileostomy has a small stoma in the right lower quadrant. And typically, more so, if you get an ostomies, more so to the right lower, right upper quadrant, that type of thing. That's pretty much where, what term do I want to use? So to follow the flow of bowel, if you are, you just ate your food then mixed in, it turns into chyme, it's traveling through the intestines. It will first travel through the right lower intestines, right upper intestines. And while it's traveling in those areas, the stool or the chyme is more so watery formed. It's more so watery form. As it's getting to the left upper quadrant, the stool is becoming more so formed. It gets to the left lower quadrant, at the colon, large intestines, it's more so formed. So some areas you expect to see more watery stool. Other areas of the colon or the intestines, rather, you expect to see more formed stew. So with an ileostomy, you expect to see more watery stew because of the location. And it talks about a colostomy. We're gonna read preoperative care. Will somebody read the first paragraph to preoperative care?
A wound, ostomy, and continence nurse should be consulted before surgery. The WOCN can help prepare the patient both emotionally and physically for the surgery. In addition, the WOCN has expertise in selecting the stoma site for the surgeon to ensure that it is easy to sit with it, care for it, and wear clothing over it. This involves observing the abdomen as the patient assumes various positions to note how clothing is worn, such as where a belt rests. The site for the stoma can then be chosen so it is visible to the patient for self-care. Avoid skin or fat folds and is placed where clothing will not interfere with the appliance. Properly planned stoma placement can prevent discomfort when sitting, inability to perform self-care, and uncomfortable, leaking, or poorly fitting appliances postoperatively.
Having a stoma, do you feel like it would affect the patient psychosocially?
Definitely.
Yeah, it definitely affects people, especially when you're dealing with younger people, you know, who are at dating ages. I don't even want to date because I don't want nobody to see this stoma. You at a family function, it's your colostomy bag or your ostomy bag then burst, you know, that type of thing. So it's some embarrassment that can come with having a stoma. And it just talks about the different locations of stomas. And the type of effluent that it has, and that's another word for like stool. And it just tells you with the ileostomy, you will expect to see liquid to mushy stool. And it's kind of giving you the travel of the intestines as you go from the right lower quadrant, work your way up to the right upper quadrant, that type of thing, where it's giving you the consistency, what type of stool do you expect to see. And anytime you think about something that's descending means it's on its way out. And the left lower quadrant, as that stool getting to the left lower quadrant, it's on its way out of the body. And that stool should be more so soft to hard form or whatever. So you want to review this table. And it talks about the nursing process for the patient with a new or established ostomy or continent ostomy. Will somebody read the first paragraph under data collection?
For a patient with a new ostomy, in addition to routine postoperative assessment, a stomach should be inspected at least every 8 hours. The stomach should be pink to red, moist, similar to the inside of the mouth, and well attached to the surrounding skin. A bluish stoma indicates inadequate blood supply. A black stoma indicates necrosis. Either complication should be reported to the HCP immediately for treatment, which may require that the patient return to surgery. No edema of the stoma. The stoma size will gradually decrease over the first few weeks following surgery.
Yeah. And with them stomas, you do have to document on the appearance as nurses. And part of documentation, nurse assess resident or patient stoma. Stoma is beefy red, is moist, surrounding skin is within normal limits for ethnicity. No signs or symptoms of infection noted. that type of thing. You have to document no drainage noted, that type of thing. You have to document what you actually observe, as well as that subjective information. And we know the subjective information is what the patient actually say. You also will have to teach patients who are independent or patients who going home. You have to teach them how to care for their, how to provide care for their stoma. You want to teach them how to care for it. If somebody else, a family member, significant other, will be providing care, we have to educate them as well. This is how you care for the stoma site, that type of thing. In some patients, depending on where the stoma is located, they do need education about the about foods that may contribute to like really watery stool, because sometimes if them with knowing that different locations may contribute to watery stool, if a lot of watery stool is constantly pouring out, that patient got to keep changing that bag. And it may actually contribute, it may affect the patient's skin integrity. Constantly having to pull that bag off, put another one on, pull a bag off, put another one on. And when you are dealing with the different bags that the patients may have to wear, some of the important things to know, even as nurses, because nurses, we definitely change these bags these patients have to wear. If it's to a point where it's stuck on the patient's skin, we don't want to yank that off. We do not want to yank that off. And, you know, it causes a skin tear or some type of skin injury. We need to use some type of normal saline or some water to rub that sticky stuff off, because we don't want to damage their skin. So you want to moisten up the sticky portion and then remove it. So there are several types of colostomy bags your patients can have. You just have to learn how to use them. And as for anything, if it's something you aren't sure of, being a nurse, you need to make sure you're asking several questions. You're asking several questions. And that is it for chapter 35, 34.